Good morning and welcome to the fourth meeting of the Health, Social Care and Sport Committee in 2026. I've received no apologies for today's meeting. The first item on our agenda is for the committee to decide whether to take items 6, 7 and 8 in private. Do members agree to take these items in private? The second item on our agenda is to take oral evidence from the Cabinet Secretary for Health and Social Care and supporting officials on the Scottish Budget for 2026-27. I welcome to the committee Neil Gray, Cabinet Secretary for Health and Social Care, Fiona Bennett, Chief Finance Officer for Health and Social Care, and Alan Morrison, Deputy Director of Health Infrastructure and Sustainability, Scottish Government. And I invite the Cabinet Secretary to make a brief opening statement.
Good morning. Good morning, Convener. Good morning, colleagues. I'd like to thank the committee for the opportunity to discuss the 26-27 Health and Social Care budget. This is a budget that delivers a record £17.6 billion for frontline NHS services, £2.4 billion to support the vital work of GPs, primary care and community services, and more than £2.3 billion in support of social care. It is also a budget that was presented to the Scottish Parliament following constructive engagement across the Chamber led by the Cabinet Secretary for Finance and Local Government. It has been developed through effective engagement and negotiation across Parliament to build broad support, and will continue to work with all parties in Parliament to secure agreement around the budget's provisions. Our health and social care services still face challenges, and that is why we will continue reform, focusing on prevention, reducing waiting times, improving access and shifting the balance of care to communities. And overall, this budget provides almost £22.5 billion of investment in health and care and social care services. There is more than £17.6 billion for health boards, providing a real terms uplift of 1.8%, with spending across the NHS rising by nearly £5 billion by the end of this Parliament, almost doubling our commitment to increase frontline spending by 20%. There is more than £2.3 billion for social care, delivering our commitment to increase funding by 25%, would have been £840 million. It supports an uplift to adult social care pay, as well as improvements to wider terms and conditions for workers. The £2.4 billion for primary care includes support for recruitment, retention and capacity, providing over £98 million additional funding for 26-27, which is part of our historic three-year £531 million deal secured with GPs. There is also a further £36 million to establish new high street walk-in GP services. 15 walk-in services will be established, with services focused on urgent, on-the-day primary care needs similar to those provided by out-of-hours GP services. And it was my pleasure to visit the first identified pilot site at the Wester Hales Healthy Living Centre as part of the Budget Week. There are funds for investment across the NHS estate, progressing priority hospital replacement projects, embarking on a primary and community care infrastructure investment programme, and undertaking targeted maintenance and equipment replacement. Importantly, there is an additional £40 million of investment for sport and physical activity to support opportunities for people across Scotland to be more active. Convener, I have no doubt that we have an NHS in Scotland that, after the profound shock to the system that was COVID, is recovering. This is a powerful health budget that will enable the ongoing challenges, notwithstanding our health services, to do more and to do it better. And with my colleagues, I'm happy to take questions from the committee.
Thank you very much, Cabinet Secretary, and we will move straight to questions and to Emma Harper.
Thank you. Thanks, Convener. Good morning, CabSec. I'm interested just to pick up on what you're saying about the walk-in GP centres, and I know you just mentioned the one that was announced in Edinburgh. So the budget assigns £36 million funding for walk-in GP clinics. Is this funding for additional staff or for other costs associated with the pilot? What further funding might need to be made in order to take this forward?
I thank Ms Harper for her question. Walk-in GP services are an important policy priority for the government in adding additional flexibility for people being able to access GP services. They're not about displacing or replacing from core services, which is why the record funding increase that's going into core GP services is so important, so we can broaden that primary care front door that's available to people. But it's about offering offering more flexibility, trying to avoid people going to the wrong place for their healthcare needs. And the funding that we have attached to this is going to be predominantly for staffing, but there will also be, depending on the sites chosen, there will also be needs for some interventions in particular sites, wherever they are.
And you mentioned also this, so the walk-in centres will support already established general practice, and I think the British Medical Association were quite pleased with how this was negotiated with the GPs, and were quite positive about it. Actually, can I just ask how the draft budget will support the GP practices separate from walk-in centres?
I thank Ms Harper for providing that distinction, because the interventions that we've been able to make through negotiation with the BMA, something that I've been keen to do from taking office, on broadening and providing greater capacity into core general practice. We've reached this landmark agreement with the BMA that they believe is a landmark that is potentially generational in its impact, and that is for the 530 million over 3 years. This budget provides the first year of that, £98 million increase. That is front-loaded towards employing additional GPs, but across the course of the deal, it's also about improving their digital offering and other elements of expansion and innovation within general practice, and their data reporting to us, so that we can really see the incredible efforts that are gone to by our general practice surgeries in providing that broad front door to the health service. And I think it was very well received by the BMA, and my appearance at the local medical committee conference in Aberdeen just before Christmas was a positive one, and I believe that there is much positivity in the GP community around what the future can hold.
And maybe just a final wee question about community support, optometry, pharmacy services. How does the budget support that direct community support for, I know that we try to move care away from the hospitals to optometrists, for instance. Is that something that this budget supports as well?
Yes, Ms Harper's correct. There is additional funding for community optometry, community audiology, the continued expansion of Pharmacy First, to ensure that people have that opportunity to access the right care in the right place, and to be able to, as I say, have that broadest possible front door. It's also about shifting the balance of care. So we're seeing more anterior eye services and community glaucoma services moving into community optometrists, and the community audiology services are due to be expanded as well, with additional investments coming through this budget.
Okay, thanks.
Elena Whittle.
Cabinet Secretary, given this committee's recent inquiry into neurodevelopmental assessment pathways, I was wondering if you're able to give any indication as to where the £7.5 million that's been announced in the budget to improve those pathways for children and young people is going to be deployed?
I thank Ms Whittam for her question. It allows me to speak about some of the work that's been done in the CAM space in supporting children and adolescent mental health services, and this additional investment that is around supporting children that also have a neurodevelopmental condition that requires diagnosis and treatment. This is about expanding the opportunities in that side of the CAMS and child and adolescent mental health services. We've done a significant amount in core CAMS services, significantly increased staffing, and as a result brought down waiting times and achieved CAMS standards across Scotland for the first time over the last year or so. We're now looking to make additional progress in an area that we recognise and the committee has recognised as a particular challenge, which is on neurodevelopmental pathways and providing the support for children and their families in achieving that diagnosis, but also their treatment. I think it is also important to stress, and I know Ms Whittam knows this well, that even without a diagnosis, our policy framework is geared towards supporting people around their need as opposed to diagnosis, although I know how much importance is attached by families to getting a treatment pathway through diagnosis, and that's what we're attempting to support here with additional investment.
Thank you. And just one wee final question for me. And you mentioned it previously and to the answer to Emma Harper. In terms of the community audiology, I'm wondering if that announcement is actually starting to set us on that pathway to having kind of parity between how we deal with opticians and optometry on the high street and how we can actually deliver those audiology services to people in their communities.
Ms Whittam is absolutely right, Convener. There are huge opportunities for us as we attempt to shift the balance of care, moving some of these clinic-based services out of a hospital and into more high street and community based services, and providing this additional funding into community audiology is about attempting to move us into that direction. There are already well-established pathways there because of free eye tests in the optometry space, and Pharmacy First has seen a significant expansion as well as the prescriber status in pharmacy has seen us move forward significantly in that space. This is about trying to match that in an area that we recognise different parts of the country have got challenges in terms of waiting time. So I'm pleased that we've been able to commit this additional resource to community audiology services as well.
Thank you.
So I think we all saw the absolute chaos that resident doctor strikes caused in the NHS in England. And the threat of that in Scotland was sending a chill down many people's spine about what impact that would have. So I was really relieved, as I'm sure a lot of people are, that those were averted by the Scottish Government coming to a pay deal with resident doctors. Is that uplift in their pay reflected in the budget, or is that going to have to be removed from what's already been set out for the health services budget for the next year?
Thank you, Convener. Yes is the short answer, that the budget reflects honouring of all pay deals that have been secured. That moment of being able to arrive at the deal that we did with the BMA Resident Doctor Committee was one that was achieved through consensus and compromise, significant compromise on both parts, and I was very pleased that we were able to do that. As you say, there would have been significant disruption. We reckon over 20,000 procedures, operations and appointments would have been cancelled in that strike period, which would have put to significant risk the incredible progress that has been made by our staff in reducing waiting times and improving access to our health service over the last 6 months in particular, but over the last year or so. And so I was very pleased that we were able to avert industrial action, and I think we've arrived at a deal now that the Resident Doctor Committee will recommend to their members, and we expect the ballot to proceed in a short order, and I hope the BMA Resident Doctor members will accept it.
Thank you. Brian Whittle.
Thank you, Convener. Good morning, Cabinet Secretary. Just a quick supplementary with regard to the walk-in GP clinics. Given that we're already short of GPs and nurses and other healthcare professionals, and it takes 10 years to train a GP, where are we going to get the staff from to staff these walk-in clinics?
So that was one of the questions that I was seeking assurance on when I visited the Wester Hales Health Centre a couple of weeks ago during Budget Week, and the board has already had significant offers of interest from GPs and wider practice staff in staffing a walk-in GP clinic. We've got a record number of GPs currently in training, and we know that there are GPs that have recently qualified in different parts of the country that are looking for employment. So this, alongside the investment, the record investment over 3 years that we're making in core GP services, which is about seeing more GPs employed in core general practice, this is going to be another opportunity for those that are coming through the system to stay in Scotland and not just train, qualify, but now live and work in Scotland. And there'll be opportunities across the country now for GPs to have a fulfilling career giving service to the people of Scotland.
If I could, if they're going across to doing the walk-in GP clinics, will that not take people away from take people away from GP surgeries?
No, the idea is that this is not to displace or replace core GP services. This is about providing additional flexibility for patients to be able to access GP services. The time that they're available is designed to ensure that core GP practices continue to predominate. They're going to be from 12 until 8, so they're looking at crossing over into the out-of-hour space, looking to try to stop people self-presenting acts in emergency that don't need to be there, that could be captured and treated within primary care services, urgent care services, and to allow greater flexibility for those that are working to be able to access GP services in a way that accessing core services sometimes is more challenging. So that's the design. Again, this is a pilot. This is about testing and learning as to whether or not this is the right model. We are taking learning from how this has worked or not in other parts of the UK and are seeking to build on that in order to provide a pilot that provides that broader front door to primary care, to our health service, and believe it's going to be very popular with the public in terms of being able to present without the need for an appointment and be able to be seen by GP services.
Thank you.
Paul Sweeney.
No.
Oh, we can't hear you, Mr. Sweeney.
Can you hear me now?
We can hear you now.
Sorry about that. Thanks, Convener. Cabinet Secretary. One area I had noticed was the alcohol and drugs policy is facing a 1.6% real terms cut, despite the fact that the latest figures still show a significant level of drug-related deaths. I think it's 1,017 in 2024. I'm obviously worried about why that is being cut in real terms, and what impact do you foresee that having on the alcohol and drugs partnerships?
I thank Mr Sweeney for his question and recognises his long-standing interest in this policy area. In terms of alcohol and drug partnerships, we've maintained a record level investment in alcohol and drug partnerships in this budget, £115 million, and expect that to be able to support the policy provisions that we have set out both in alcohol and drug services. Mr Sweeney will be aware that we're currently reviewing our national mission, but also on tackling drug-related deaths, but also our alcohol policy, and we're expected to publish that in very short order, and we'll be using that as an additional policy lever to ensure that we are targeting our resources that are available to continue to drive down on drug and alcohol-related deaths.
There was one issue that came up in the Cross Committee on drug-related deaths, which was analysis of the Thistle and its ongoing performance. I know there's a budget allocated to that pilot, but something that has emerged in discussions was the change in use patterns and street injection from heroin to cocaine, and because there's a much greater frequency of injection, it's more likely to be needed overnight. So there was discussion about it would be beneficial to change the business operating model of the Thistle to have an overnight provision, so moving more towards 24 hours. There obviously would be financial implications for that. Would the Cabinet Secretary undertake to at least engage with the Glasgow Health and Social Care Partnership about the prospects of that adjustment to the service, given the complaints about needle discards, etc., but that's actually associated with more frequent usage overnight because of cocaine. It's just an example of how we need to be agile with adapting service provision to meet changing behaviour, but maybe that could be constrained by financial issues, or if there is a cut to this budget.
Mr Sweeney's correct that the prevalence of cocaine within drug-related harm is increasing and is causing us considerable concern around its proliferation and the additional harms that we're seeing caused by that increased proliferation. The service model for the Thistle, first of all, appears to be going well. We're seeing the service being well used and lives are undoubtedly being saved. We've seen a number of medical emergencies being responded to at the Thistle, demonstrating, I think, in an early stage that it appears to be working as intended. And in terms of that ask that Mr Sweeney makes in terms of adjusting its service model, that would be requiring conversations both with ourselves, Marie Todd as the lead minister, and the local health and social care partnership as to whether or not that is something they want to move to. There's been other discussions as well and other asks that I think Mr Sweeney has made and others around inhalation services, and all of these areas remain under consideration, but the current service model applies at the moment, but obviously, as Mr Sweeney says, we need to be agile to emerging threats. We know where these are coming from. We understand the threats that they cause, including those of synthetic opioids and nitazines, and we will do what we can to ensure that our services are adaptable to meet those challenges.
Thanks, Convener. Just to go back to general practice, ScotGem, the Graduate Entry to Medicine programme, has been really successful for Dumfries and Galloway in terms of retention and that. Can you say a wee bit about how ScotGem, it is unique to Scotland, is it successful?
Well, I think it absolutely is, and as a rural MSP, I know that Emma Harper takes a particular interest in this, and I think it has delivered benefits for areas like Dumfries and Galloway, and it is around providing specialist education and training for people in rural practice, and then giving them additional incentive to remain here because of that additional level of training and education. We continue to evaluate ScotGem and its effectiveness at providing our rural communities with medical practitioners that can be sustained in those communities, which is, as I say, born and bred in Orkney, I recognise the challenge of recruiting and retaining staff members in communities like this. So I think it is successful, and I'd be happy to provide committee with more evidence around its work and its effectiveness.
Okay, thanks.
David Torrance.
Thank you, Convener. Good morning, Cabinet Secretary and officials. The budget states that certain funding streams are now baselined in the board's budgets, and this has resulted in larger uplifts than would otherwise be the case. To what extent do board uplifts reflect the baselining of funding streams, and to what extent are they due to other factors?
So there is increased baselining. This is to provide additional transparency, but as has been asked for by committee, but also by the organisations like Audit Scotland, but also to provide greater certainty to our boards around their funding provisions. And I think we set out in my response to committee some of those areas of increased baselining. But if there's more information required on that, I'm happy to provide it in writing.
Cabinet Secretary, what progress has been made in addressing the concerns relating to financial management that have resulted in 6 of the territorial boards being placed in Stage 3 or 4 performance escalation framework? The Financial Delivery Unit of the Scottish Government supports all boards on their financial performance, and there are enhanced support available to those boards that are furthest from balance. The number of boards in that category has reduced over recent years, and we, led by Fiona Bennett, we are providing increased level of support to those boards that are further away from balance, in order that they manage their balances down whilst also maintaining service provision. And I think a good example of that in recent times has been the escalation of NHS Grampian. And I believe the new leadership within NHS Grampian is getting a very strong grip on the financial perspective, but is also focused in on ensuring that we see improvements in service delivery as well. And it's that assurance board process that the government helps to provide at level 4 that allows boards to have additional areas of support and attempts to see a further a de-escalation when they're in a better position.
Cabinet Secretary, can you provide an update on the current status of the NRAC review?
I don't have an update at this stage. There is an increased funding in the budget, I believe £36 million, to ensure that all boards remain within a very narrow gap of NRAC, and to ensure that funding fairness that comes through the NRAC formula can be maintained. It makes sure that we are accounting for rurality and other demographic issues in terms of service delivery, and provides the fairest possible route to achieve that. But I don't know if we've got any further update in terms of the NRAP review that Ms Bennett might be able to help me with.
Yeah, just to note that we do review the formula yearly, so it is updated in terms of population estimates, in terms of some of those rurality demographic factors that Cabinet Secretary mentioned, so it is reviewed each year. Ultimately, we've decided not to do a full-scale review at the moment, because ultimately the pot of funding would still be the pot of funding, and we don't want to disadvantage services that are starting to make progress. So it is reviewed each year, but no sort of fundamental review of that formula is underway at the moment.
Thank you. No further questions.
Sanders Gohani.
Thank you, Convener. Declaration of interest as a practising NHS GP. Morning, Cabinet Secretary. Given NHS Greater Glasgow and Clyde are getting a 7.7% increase in their budget, given the hideous nature of cover-up and scandal we are seeing in the Queen Elizabeth Hospital, is it fair that this increase needs to come along with far greater scrutiny of the board, and will you be putting it into special measures?
The board is under significant scrutiny because of the measures that have been taken by the government in establishing a statutory public inquiry, independent of government, judge-led, and I think the truth that has been sought and the answers that's been sought by the families affected, for whom my deepest sympathies go out today, that is the reason we are going to get access to the truth, and I believe it's important that the public inquiry is able to do its job independently without interference from government.
Thank you. You're absolutely right. There should be no interference, but NHS Greater Glasgow and Clyde admitted that there is a causal link. And given that admission, given the horrible nature of the apology given by a lawyer, it seems that increasing money going to them should come with conditions, and it should come with being placed into special measures.
The first thing to say is that the leadership of NHS Greater Glasgow and Clyde is substantially different to that of the period under scrutiny through the public inquiry. It is still important that services are able to be provided now by NHS Greater Glasgow and Clyde, stretching beyond the Queen Elizabeth across all aspects of service in Greater Glasgow and Clyde. And of course they are subject to the highest scrutiny possible in terms of the public inquiry, but also the annual board reviews and other official-led processes that take place throughout the course of the year. So scrutiny and conditions being attached to the statutory responsibilities that they have to deliver services are a normal course of affairs in terms of the resource allocations that are provided to health boards, and on top of that they have the additional scrutiny of the independent judge-led public inquiry.
Thank you.
Gillian Mackay.
Thanks, Convener. The Coalition of Care and Support Providers is concerned by an apparent change in policy on social care pay. They've stated that instead of increasing the available funds from £12.60, or the real living wage for 25-26, to £13.45, the real living wage for 26-27, the Scottish Government seems to have chosen to only fund an increase from the new national living wage in 26-27. This means that the pay fund would only cover an uplift from £12.71 to £13.45, 11 pence an hour less than providers expected. This will result in a funding shortfall which COSLA suggests is £15 million for adult social care services and £4 million for children's services. Could the Cabinet Secretary confirm that the fund to increase pay and commission social care has been baselined to the national living wage rather than the real living wage as expected?
I thank Ms Mackay for her question. She's correct in her assertion, and this was set out by the Cabinet Secretary in the Finance Committee debate, I think last week, where our position is that employers should be responsible for statutory employment costs. That takes you to the minimum wage elements, and we are then funding the difference from the statutory responsibility to the real living wage. I've received the correspondence from Rachel Cackett from the CCPS. I've also met with COSLA's political representative in this space, Councillor Paul Kelly, and discussions in this area are ongoing. We recognise the challenges that there are in the social care sector. That's why we've increased social care investment to over £2.3 billion. We are continuing to fund increases to social care pay. That takes us to over £1 billion, I believe it is, investment in social care pay. But we also recognise the pressure that they're under, so discussions are ongoing.
What consultation did Government have with the sector on the implications of this decision on jobs and services, and was there an equality impact assessment completed?
So equality impacts assessments are completed across portfolio areas, and that is the normal course of budget setting. In terms of consultation, discussions are ongoing with the sector, and we have remained committed in a very tight financial envelope to supporting social care pay. That takes us to the real living wage. I don't believe that is matched in all other parts of the UK. We're continuing to do that in spite of the difficult financial circumstances of this budget settlement, and we will continue to meet and discuss the implications with the likes of CCPS and others in the social care employers in the social care space to ensure that we're doing everything we possibly can to support these critical services that touch the lives of so many families across Scotland, including mine.
Thanks, Convener.
Thanks. Of course, Cabinet Secretary, you've spoken in the past about challenges caused for the social care sector by the UK Labour Government's changes to immigration and visas, and I know that the number of accepted visas is down drastically. Donald McCaskill of the care sector has been very critical of the impact of employer national insurance contributions and how the hikes in those have impacted social care employers. Is this budget aiming to combat any of that impact caused by the UK Government on social care in Scotland?
Thank you, Convener. There are two areas there. The first is around migration policies of the UK Government, which are causing significant harm to service delivery here in Scotland. Donald McCaskill has said so, as you quote, Convener. Social health and care visas from this UK Government are down around 80% as compared to the last Conservative Government, which, given the population demographics in Scotland as a whole, but in certain parts, in particular in rural and island communities, is absolutely devastating. The biggest resource challenges exist in many health and social care partnerships. I recognise that, but the largest issue and the largest challenge facing the sector is access to staff, and when one route is being cut off in the way that it is by the UK government, it makes it incredibly difficult to sustain services. So we've made significant representation as has the sector, to try to see that those migration policies changed, and if not, to allow us to have our own rules around migration, so that we can have a service that's going to meet the needs of the people of Scotland. You also reference correctly the impact that increases to employer national insurance contributions is making. This is estimated last year, I don't have the figure for this year, to be over £80 million for social care providers, which is, given what we've just been speaking about around the support for care wages going to the real living wage, highlights the detriment to this service. We have called for that to be reversed or for it to be fully funded, neither of which has come through, and so the challenge to the sector through those two areas alone is profound, and those are areas that we have no direct control over. On the migration point, however, Convener, you'll have noticed in autumn last year we committed to come forward with a scheme to support displaced international workers in other parts of the UK. That has been incredibly successful, and the First Minister announced its extension earlier this year to allow those that have visas, are in the UK but have no employment currently, to find their way to Scotland to be able to contribute to social care services in Scotland. That's been incredibly successful, and I'm proud of the fact that we are doing what we can within the rules to support migrant workers here in Scotland.
Thanks, Cabinet Secretary. And I should put on record that I hold a bank nurse contract with Greater Glasgow and Clyde NHS. Brian Whittle.
Thank you, Convener. Just on that point, and when we're seeking to fill so many of the spaces within our social care sector, how do you answer, and I've asked you this before, Cabinet Secretary, we have pupils who want to go into the social care sector, who are applying to colleges across Scotland and being turned away because the colleges have a lack of funds. I know that Ayrshire College, with 71 applications they had to turn away for their social care courses, and other colleagues from across the chamber highlighted similar issues across Scotland. Surely that's something we should be tackling if we have this significant need within their social care.
I've visited some of our colleges providing health and care training. They provide an incredible service, and we've got an enthusiastic young workforce coming through. I can tell Mr Whittle, who are, don't seek to be patronising, truly inspiring in terms of their application. We have provided increased resource for colleges in this budget. I think it's an additional £70 million. I may need to be stand corrected if that figure is incorrect, but a significant additional resource going to colleges, because we recognise the fundamental role that they play within our economy and the education system, and for our public services like health and care, in ensuring that we've got the workforce to meet the needs of our public services and meet the needs of the people of Scotland.
Sorry, but the cost of recruitment, if we don't go through the colleges, it would be offset if you allowed more places into college. If we're short of places and we have people who want to take part in our social care, and our own homegrown people who want to work in social care, surely the best route to do it would be allow more places at college and fund more places at colleges.
Well, we're seeking to do both. I would argue, Convener. We are providing significant additional resource to our college sector in order that they can provide additional spaces. But we are also, given our demographic projections, we are in need of people of working age of a working age to come to Scotland, because we do not have the current people that are able to fill all of the needs within services across Scotland and meet the needs needs of the wider economy. So we need migration in order to sustain our public services and our economy. But that comes as both. We need to do train and support people to come through the system. Of course we do. We're sustaining additional resource for the college sector to do that. But we also heavily rely on migrant labour. That will continue because of our demographic challenges, where we're going to see a falling working age population in years to come. And so that's why we need a migration system that's going to work in the interests of our services and our wider economy here in Scotland.
Thank you, Convener.
Carol Mochan.
Convener. I mean, the Cabinet Secretary will recognise that it is our job to scrutinise the Scottish Government here in committee. So I just wondered, you did mention the investment in social care, but it is difficult to track the spending. It's difficult to track what's been transferred from health into social care. And I wonder if there is anything the Cabinet Secretary can do to help us with that. Could you make any commitments around this sort of transparency of where the money is likely to end up?
The first point, as a former committee convener, I recognise and place incredible value upon the role of our committees scrutinising government, and I welcome the opportunity to be here to be scrutinising the decisions that we're making. Of course, I'm happy to bring in Ms Bennett again in terms of the detail of this, but in the correspondence that I sent back to committee on pre-budget scrutiny, I did set out a number of steps that have been taken in order to improve transparency around budget setting in the social care space, in the mental health space, where there was significant attention last year. We want to aid and support that. I think I've already set that out in terms of my answer to an earlier question, but I'm happy to bring in Ms Bennett if there is more detail that can be provided to the question that Ms Mochan raises.
Yeah, I'm very happy to provide and write a breakdown of that 2.3 billion, so as you can exactly see where that's gone. And the reason that I think it's very important that we transfer that into the local government baseline is so as they've got certainty of that funding, but we can certainly provide that historical breakdown of what makes up that 2.3 billion figure.
That would be very helpful. Can I just ask the Cabinet Secretary, in terms of the real living wage in adult social care, you know, do you recognise COSLA's sort of figures in terms of the 160 million allocated, but they estimate 175 million to deliver it in terms of that real living wage? And you know, do you have a plan to work with COSLA to see how we make sure that that really important workforce does get that uplift?
I thank Ms Mochan for the question, which builds on the answers that I gave to Ms Mackay. The first point is that the government's position for this budget has been that employers should be meeting their statutory pay obligations. So meeting the minimum wage is a legal responsibility that employers have got. What we have set out to do is provide the additional resource that goes from the minimum wage to the real living wage. I recognise that that means that compared to previous years there is a gap. As I set out in response to Ms Mackay, I've met with COSLA already. I've received correspondence, the government rather has received correspondence from the likes of Rachel Cackett from CCPS, and discussions are ongoing in that space. We recognise and value our social care staff. That's why we're providing the increased resource in order to support them being paid at least the real living wage. And that is a policy that is not matched in all parts of the UK, but in spite of the very tight fiscal settlement that we have, we've still maintained that commitment, and we'll continue to work with COSLA and employers on what the settlement means.
I've just got one more question, if that's okay. It's just a question in terms of the way in which the budgets work, and whether the government have looked at, you know, rather than transferring into local government, whether from the outside that money might be allocated directly to local government. It's just whether you have had that kind of discussion about the future way in which it will work.
I'll need to check with double check with Ms Bennett, but I believe that the real living wage funding has been baselined to local government's budget. Ms Bennett's nodding, so some of that has been baselined over.
That's fine. Thank you very much. Thank you.
Anders Gohani.
Thank you, Convener. Cabinet Secretary, you earlier spoke of the importance of free eye care, but I noticed that in real terms, the community eye care budget has fallen. We're also seeing a reduction in the money that's going to reform and improvement measures. So that's 2.2% in real terms. Now, given that that is part of improving discharge without delay, improving A&E performance and hospital at home, and the latest figures that we're seeing at the moment for A&E waits, surely those things are not compatible with each other.
Thank you, Convener. The comparison that I think that Dr Gohani makes is from opening budget to opening budget, through the autumn budget revision to opening budget. There is still opportunity for in-year movement within budgets to support either demand-led services or indeed for improvement, reform and improvement services taken forward. So in that sense, the work that's been done to reduce waiting times expanded significantly in year from the opening budget position last year, and there are significant structural reform improvements going on to ensure that the efficiency and productivity and optimising capacity across the service through measures such as subnational planning, so planning for our planned care system on a larger population basis, will we believe mean that we are getting a similar or better outturn to the investment that we're making. So we'll get, in effect, better bang for our buck in terms of investment that we're being put into the system.
Okay, so a drop in the budget is going to make an improvement for these things. Okay, I noticed in the latest budget on the capital projects, there is a real terms 4.5% decrease in the budget. What does that mean for national care treatment centres?
We've, as Dr Gohani knows, we've set out the priority projects that are being funded through the capital programme, Monklands, iPavilion, the Belford and the joint campus on Barra. We've also set out in the infrastructure investment plan a series of primary care investment projects which will come forward through a revenue finance model. In due course, that's under consideration with the Scottish Futures Trust at the moment. Our capital budget has been squeezed and continues to be squeezed by successive UK government budgets, and that means that the investment that we're able to make on capital projects such as new hospitals, new health centres, on digital and other investments are more challenging, especially after we consider the corrosive impact that inflation has had over the last 3 or 4 years. Our public pound is not able to go as far through construction inflation spiralling. So these are challenging and difficult decisions that we're having to make, but we have set out our priorities in a transparent way through the budget and the infrastructure investment plan, and we continue to invest in repairs and maintenance as well as new equipment in order that we've got the best service possible for the people of Scotland.
Well, I noticed you didn't actually answer the question about the national treatment centres. What would it mean for the ones that are paused?
Forgive me.
But just to roll that into my next question, we the Scottish Conservatives have an FOI which shows that NHS Ayrshire wants to sell Carrickglen. So again, what does it mean to national treatment centres, and what will you allow NHS Ayrshire to sell Carrickglen?
So first of all, in Carrickglen, there are processes that need to be gone through before any commitment can be made to sell a site, and that is what I wanted to ensure and satisfy myself of. Those discussions are ongoing. In terms of the national treatment centres, we are making investments in areas like Gartnavel, Perth Royal Infirmary, Stracathro hospitals to protect planned care services on those sites. So So whilst we haven't put forward capital because we don't have sufficient capital to do it for new build National Treatment Centre sites, we are moving to a model of protecting planned care on a larger population basis, which is the policy intent behind constructing new national treatment centres and seeking to provide that within existing services until we're a position where new capital comes available should the position of a UK government change.
So is it fair to say for now you're abandoning your flagship national treatment centres?
No, the policy intent remains. I've set that out, and the pipeline of new national treatment centres is, as in physical buildings, is paused, but the policy intent has continued in terms of the investments that have gone into Gartnavel, into Perth Royal Infirmary, into Stracathro, in order to protect planned care services in those facilities.
Thank you.
Can I just ask briefly about the financing of some of these capital projects? So the infrastructure delivery plan indicates the intention to return to private financing to deliver community health centres. Now, we've seen the legacy that PFI has left, the huge debt that needs to be repaid every year. So can the Cabinet Secretary provide assurance as to how value for money will be ensured in the use of such financing?
Absolutely, that's the work that is underway through the Scottish Futures Trust in order to ensure that the very stringent value for money tests that are associated with spending decisions through the Scottish Government can be met, but also in the absence of conventional capital becoming available from successive UK governments squeezing our capital budget, then we need to look at making sure that in the primary care space we need to have primary care spaces that are bigger, that are more flexible to meet the need of shift in the balance of care. We're going to be asking our primary care practitioners to be doing more as we move services that we've already spoken about from hospital-based clinics into the community. So we're going to need infrastructure to meet that need, which is why I've asked my colleagues in government, Mr Morrison leads this work, to find a model that meets that public value test, but also allows us to proceed with capital investment that allows the policy intent of government for more services to be delivered within the community to be realised.
So that legacy of PFI that continues to squeeze budgets year in, year out on Scottish Government and local authorities, that will not be continued with this new model of financing?
No, the extortionate PFI costs will not be emulated. We will be looking at a different model, one that ensures we are protecting the public finances as best we can.
Thank you. Brian Whittle.
Thank you, Convener. I'd like to go back to the Carrick Glen issue. When it was first mooted, it was mooted as a step down, step up health centre that would alleviate a lot of the pressure that's in the front door of the A&E, and it would make sure that people were being treated in the right way and at the right time, getting the right health care that they require, and rather than either be in the community or be in hospital. And I have to say that's a model that I personally would support enthusiastically. But the reality is now that looks like it's not going to happen. And it's been reported that some £5 million has already been spent in recruitment specifically for Carrick Glen, which looks like it's not going to happen. The reality is, Cabinet Secretary, the Ayrshire are in a significant deficit. That's the reality of why Carrick Glen's not happening, isn't it?
No, I've already set out the perspective of the overall capital budget that has not allowed us to progress Carrick Glen at this stage. The investment in human resources and people to staff such a facility will have been utilised in other parts of the system. Ayrshire and Arran has a very effective frailty at the front door service that I was able to see at University Hospital Ayr very recently, and that is doing great work at supporting some of our frailer patients who tend to come in and out of hospital, have longer lengths of stay as a result, and their condition continues to deteriorate, meaning that when they do return home, they require increased social care intervention. What their frailty service, that I believe will have been staffed by some of those that were employed, as Mr Whittle sets out, has been utilised on that service, and as a result has seen a reduction in admittance to hospital and a reduction in length of stay for those with frailty, both of which are incredibly beneficial to those patients and ensure a better flow within the system for the wider system, but most importantly, a better service for those patients.
I'm an Ayrshire boy, and Ayrshire and Arran is my local health board, and I can tell you they're under enormous pressure at the front door. And I put it to you, Cabinet Secretary, that by not going ahead with Carrick Glen, it's a false economy, and all we're going to do is see these significant waits at A&E and significantly longer stays in hospital if we don't go ahead with that kind of plan.
Well, I think I've made clear, Convener, that we wanted to proceed with the National Treatment Centres programme as was laid out. We believed that that was going to be the best way of reducing waiting times. The capital position has been such, both in terms of construction inflation. We all are aware of the corrosive impact that inflation has had over recent years. And the reduction, the real terms reduction in our conventional capital budget that's come from UK government decisions means that we have been posed with very difficult choices to make. We've had to pause the majority of the capital programme in health. We're restarting now in priority areas such as Monklands, the Belford, the joint campus in Barra, the Eye Pavilion, Princess Alexandra Eye Pavilion in Edinburgh, as well as looking at what we can do around a revenue finance model for primary care facilities, so that in spite of the capital settlement that we have received, we are still able to make progress on building infrastructure that meets the needs of a modern health and social care service.
And a brief supplementary from Paul Sweeney.
Thank you, Convener. Just wanted to raise the issue of preventative spend and obviously the interdependence between social care and acute care, particularly this issue about differential pay settlements. We've seen this already play out in hospices where there was issues with differential pay affecting capacity. How are social care providers who are already eating into reserves able to fund underfunded or cover underfunded contracts? Will this not just further exacerbate recruitment and retention of staff and reduce service availability? We've already seen a significant decline in care beds across Scotland, which have a direct impact on delayed discharge. Did the Cabinet Secretary recognise this as a significant risk?
There's a number of elements there. First of all, there's £6.5 million in the budget to support hospices to match Agenda for Change pay rates. So I think Mr Sweeney will be satisfied in that space. In terms of social care, I've answered in detail the points that have been raised by Ms Mackay and Ms Mochan in terms of the choices that we've made around the statutory obligation of employers to meet legal pay requirements. We have taken steps to increase social care investment, over £2.3 billion now, and that includes over this winter supporting boards and partnerships, in some cases to purchase social care beds, because that is a better option for patients, but also a more cost-effective option for the system than seeing people stay within the acute sector. So we're doing what we can within the resources that we have available to us. We're working with COSLA, with our health and social care partners. We meet on an almost weekly basis in order to understand the pressures within the system and provide the best possible support. And we are doing what is I believe, not matched in all other parts of the UK, which is to fund to at least the real living wage for social care pay. That is an investment over recent years of over £1 billion now in social care pay. I recognise the challenges that there are. I recognise what Mr Sweeney and others have set out in terms of the pressures within social care, but we have given the prioritisation that we can within the budget envelope we have.
I'm curious though, but the expectation seems to be that
we need to move on. Joe Fitzpatrick's actually covering the preventative spend theme next, so you might want to come back with a further supplementary.
Okay.
Joe Fitzpatrick.
Thanks, Convener. As you said, I want to cover preventative spend, but I also want to cover the mental health budget as well, so I'll start there. Given that the latest data we have for mental health spending relates to 2023-24, are you able to give us a commitment that we can get more timely analysis of mental health spending patterns going forward?
Yes, as I set out in the budget, the analysis letter to committee, I'm happy to provide and I think Ms Bennett has already given this commitment in other areas. I'm happy to do what we can to provide that transparency in the data as best we can for what we've got available to us.
That's really helpful, thanks. The kind of other area in terms of the mental health budgets that I'm keen to explore a little bit is obviously there's a degree of the mental health budgets have now been baselined. That feels like a good thing to be doing, but obviously it makes our job a little bit more difficult in terms of being able to see where the money is. So just whether there's a commitment to making sure that there's as much transparency, well, obviously recognising that baselining these kind of budgets is a good thing.
I recognise that. We know that between our direct investments from government and the decisions that are taken by health boards, we're expecting mental health provision to be over £1.5 billion this year. But I recognise the challenge in scrutinising that when you've got different board areas that are going to be taking different decisions based on their level of need. And so I understand how that will be challenging to read, but of course we'll do what we can to provide as much data as we can in that space.
Yeah. Okay, thanks very much. That'll be appreciated by future committees, I'm sure. Moving on to the preventative spending area, but sticking first maybe with mental health, we know that there's some fantastic examples of where early spend is having an impact. Dundee being one example where the Hope Centre is having a real impact now, and hopefully we potentially see the benefits of people not being in crisis because of that spend. That spend's always done in partnership. It's never just the health board, or it's always a partnership, often with third sector. How do we make sure that we keep that focus on partnership working?
I've been very clear, bless you, I've been very clear with my board chairs and chief executives of the importance of partnership working with the community and voluntary sector. We have to recognise, and I absolutely do, and I think I've set this out in a previous evidence session in response to questions from Ms Mackay. I very much recognise the fact that our community and voluntary organisations can often reach people better than our statutory services can, just by the nature of their embeddedness within communities and the specialist nature of the services that they provide. So I've been very clear with chairs and chief executives of the need to make sure that there's continued collaboration with services like Mr Fitzpatrick references in Dundee, that from a preventative basis and a long-term condition management perspective can provide significant benefits to individuals, but also to our services as well.
So when I joined this Parliament in 2007, I sat on the Finance Committee at that time, and preventative spend, spend to save, was kind of one of the things that has been a continuous goal of the Parliament since then, and probably before. But it's difficult to do, and it's difficult to track where money is being spent for that purpose. And so I know the government is making some efforts at being able to understand where spending is preventative spending, so that the shift can then come at a later stage. I wonder if you want to say a little bit about the work you're doing in that area.
I think Ms Robeson has given evidence next door, probably touching on these very areas. I have set out, as an example to Mr Fitzpatrick, the investment that we're making into general practice. I see that very much as being one of the headline areas of preventative spend that we're seeking to make, because of the work, particularly around enhanced services such as cardiovascular disease testing that we've put into place last year. We're able to spot much earlier and been able to have better disease management as a result, issues within general practice. We can only do that to a greater extent if we increase the capacity. And so that was the philosophy behind my approach to seeking to increase capacity within general practice. It was very much in a preventative space, moving much further upstream in our intervention, rather than, another case in point, in the mental health space, allowing it to escalate till it becomes an acute problem, and then we see, it seems callous to say it in a pounds and pence sense, but we all know that it's much more costly to intervene at a later stage in the acute system than it is earlier in the community and primary care space. So that was the philosophy for the approach to expanding the provision and capacity within general practice. There are other areas around hospital at home that I think are similarly very effective in a preventative space, preventing the further escalation, hospitalisation of individuals. And actually in some areas, in some rural and island communities, they're using hospital at home in order to meet the capacity requirements of incredibly complex social care that otherwise may not have been met. So recognising that the demand and the complexity and the infirmity in some cases of people accessing social care, sometimes that's a challenge to meet purely on a social care basis. Hospital at home is allowing us to do more of that and give people the opportunity to live in the comfort of their own home and receive a fantastic service.
You kind of alluded to it, but I mean, sometimes the human costs and human benefits are difficult to judge. I mean, kind of look at financial terms, but I've certainly experience of hospital at home, and the human benefit of that is equal to potentially the financial benefits. Looking at some in response to the committee, you talked about some of the tools you're using. So one of the things that you talked about in response to the committee was the investment and value board. So I wondered just if you could say a few words about that.
Yeah, I'll take Ms Bennett in to provide more detail, but making sure that we're taking an evidence-based approach to the decisions that we're making, and looking at that in as broad a range as possible is incredibly important. But I think Ms Bennett might be able to provide more detail on the mechanisms that are in play. Thanks.
Yeah, certainly. So we've established the Investment and Value Board, which I chair, and for the first time we've got NHS boards and integration authorities represented on that, so as they understand the decisions that are made within our portfolio and what that does for the sector. We look at all allocations coming through to ensure that they are still providing value for money, and to look at if there's any opportunity to do things differently. But we also use a sort of quite holistic analytical tool that looks at some of those prevention aspects as well as the pounds and the pence, so it's trying to give that kind of really rounded view, and all allocations from our portfolio go through that process.
That's brilliant. Thanks very much. Thank you. Thanks, Convener.
Emma Harper.
Thanks, Convener. It's a quick supplementary about prevention. It's not just the health portfolio that helps support prevention, because there's the housing portfolio. We know if we've got good housing, that helps people have better lung health, for instance, if they're not living in damp homes. So I just wondered if you could just mention a little bit about the cross-portfolio working that is required in order to support health prevention measures.
Ms Harper is absolutely correct, and she mentions housing, undoubted linkage between housing and good health, and I also think another example, another policy area that I would take, where I think health and social care is probably the greatest beneficiary, is going to be our action to address child poverty, because we know poverty is one of the greatest determinants of poor health, not just amongst children, but their long-term health trajectories, and so the work that's been done there across government, and it is being done on a cross-government basis, a cabinet subcommittee of which I'm a member to address child poverty, leads on looking at how we can have cross-portfolio attention given to those areas, so that it's not a pot of money going to one area of government being spent there, and we're not looking at the wider benefits that are being brought. And when we've got a difficult fiscal environment, making sure that we understand where decisions are being taken that can have a multiplicity of benefits across other portfolio areas is absolutely critical. And so housing is one area, addressing child poverty is another, looking at the climate change plan and working our way through the environmental factors that drive poor health is another. So those are all areas that we work collaboratively on across government.
Okay, thanks. Thanks.
Paul Sweeney.
Thank you, Convener. Just want to clarify the Cabinet Secretary's perspective on wholly publicly funded service providers in social care delivering public services wholly through taxpayer funding. How can they possibly pay for a gap in uplift of pay for staff? I'm not. It seemed to be inferred from the Cabinet Secretary that the employer should meet that gap through reserves or through some other form of revenue generation. But if these are councils, COSLA and charities, I'm just not sure how that is possible. I just wondered if the Cabinet Secretary could further elaborate on his expectation, given this is a change an approach from the government, because pay uplifts for frontline staff and those contracts have previously been covered by government pay policy.
Well, with respect to Mr Sweeney, I would extend that to the increases to national insurance contributions that are having a significant and very damaging impact on our ability of service providers in the social care space to be able to conduct their work. We have provided uplifts on pay to support and recognise the fact that in a competitive economy, I've already set this out to Mr Whittle, and a working age population demographic that is set to decline, we need to make sure that we have competitive rates of pay in the social care space and other public sector spaces in order to ensure that we are getting access to staff as best we possibly can. Also, the care home rate is set by COSLA through negotiation with the system, so there are other cogs in these wheels that have to be considered in terms of the income and the route through which social care provision is provided. I do recognise the challenge that is there in terms of meeting pay costs. Of course I do. That's why we're providing the increase that we are and asking employers to provide the statutory elements. But of course, we will do what we can to continue that discussion on the implications of the decisions that have been taken and seek to ensure that the social care sector continues to be able to provide the incredible service that it does to families across the country.
The CCPS have told me that there has been no discussion and they're completely blindsided by it. And I take the point about the need for visas to support the demographic challenges in Scotland, but there are 40,000, a pool of 40,000 currently in the care system who are unallocated or unsponsored, who can be absorbed at the point in time. But the issue also is that is £12.82 an hour is the minimum for a social care worker visa sponsorship, but the minimum adult wage for social care workers in Scotland is £12.60. So just further demonstrates how uncompetitive pay rates currently are in the sector. And again, I'm just not clear where the uplift can be funded by these providers. They're just not set up to provide that gap. And I take the point also about ENICs. Maybe I wouldn't have agreed with that approach, but there is a trade-off. If you raise tax revenue, you spend it on higher public services. So, I mean, where's the money? Where is this extra uplift? Surely it should have been used to at least cover this gap.
Again, Convener, I make the point that the visa threshold decisions are ones that are not made by us, they're made by UK government, and that perhaps partly illustrates the reason as to why health and care visas have reduced by around 80% over the last year that we have data for. We think that's detrimental to our sector in Scotland, and we want to see that reversed and better collaboration, if not the policy levers that would allow us to be able to attract and retain people here in Scotland. He is correct in his assertion that there are displaced workers across the UK. We've sought to target those through the investments that we've made in visa support that the First Minister has announced the extension of. And we will continue. I've received the correspondence from CCPS, from Rachel Cackett, with whom I and Mr Arthur engage with regularly, and we'll continue to engage with the sector as to the impact and whether there are any mitigations that can be brought forward through the decisions that have been taken.
Okay, thank you.
Thank you, Convener. Just, I was really interested in Joe Fitzpatrick's questions there, indicating that from 2007 we've been going after this preventative spend and looking how we, how we develop that preventative spend. How are you measuring the impact of preventative spend?
That, as Mr Fitzpatrick set out, it is incredibly difficult to do because it's difficult to measure something that you've prevented. However, we know, and I think that Mr Whittle and I have a similar ideological philosophy around the power of sport. For instance, we understand the benefits that come from a mental and physical health perspective in expanding people's ability to be physically active. And so another area that I would point to in terms of that comes in my mind in a preventative spend area is around the sport budget. We've expanded that by £40 million this year, and I was just in discussions with the Scottish Football Association last week alongside Ms Todd around how we can make best use of the Summer of Sport activation to go alongside the Commonwealth Games and the men's qualification for the Football World Cup this summer. A huge opportunity for us to take forward, incredibly beneficial, but crucially has to be long-lasting and sustained intervention to support people to continue in sport. But I think him and I would agree on that being an area of proven preventative intervention. But it is difficult to measure the things that you've prevented by the very nature of the fact that you've prevented them.
I have to disagree with that. You'll not be surprised to say I'm going to come on to sport, but we have lowering life expectancy. We're one of the unhealthiest nations in Europe and getting worse. We have crucially really high drug and alcohol deaths and issues. We have the highest obesity level in Europe, and we have really high levels of mental health. That's how you measure preventative spend, because at the end of the day, that's what we're trying to prevent, and we're not doing that. So if I come on to sport, and you're right, I think we do agree the impact that sport and physical activity in general can have on health and mental well-being and general overall well-being. The sports budget, when I came in here, was 44 million, and last year it was 36 million, and now it's been increasing. You'll never get an argument from me about increasing the sports budget. But the devil's in the detail. Some of this funding is one-off activities related to Commonwealth Games and FIFA. I'll be interested to see whether or not that Sports Scotland will be delivering the extracurricular activity in schools. Again, very welcome, because I think that's hugely important. The reality is in sport is that on the front line they are really struggling to even develop basic programmes. So how when you're looking at the sports budget, you're telling me in the round, you haven't doubled the sports budget from your last manifesto that you said you would do within this term. It's going into next term. Given that your commitment to sport, how can you claim that what we've done so far over this last term has been beneficial to sport?
We're not far off doubling, I think Mr Whittle would acknowledge. And I recognise, we have recognised the challenge that there is there. And in setting this budget, we've done it in collaboration with the sports governing bodies who we meet with and collaborate with closely. And the part of the consideration here was around deliverability, to Mr Whittle's point around the challenge of delivering some of the provisions that we're speaking of, and there is a confidence around what we have set out there, for instance in the swimming offer, or indeed the interventions and support that we're making around Summer of Sport, or indeed the support that we're providing to sports governing bodies, that they will be able to deliver against the investment that has been made. And I'm very pleased to see that. I've got a very clear attachment to this area of policy. I've got a hinterland that has undoubtedly benefited me, and I'm seeking to ensure that people, other children, young people, but also other adults are able to benefit from the opportunities that Mr Whittle and I both had in terms of accessing sport. But also, he's right to say physical activity, and there's a significant continued investment and intervention around active travel and work in that space as well.
Can I just touch on the swimming lesson, universal swimming lessons, which again, as you know, I've been calling for that all along, and it's very welcome to hear that narrative. However, it's not during school term, so I always think you should take sport to the kids, not wait for kids to come to the sport. And how will they, if it's during the holiday period, how will kids actually access that? Because you're potentially creating a problem here in that you still have to be able to travel. You still have to have a swimming pool that's open. You still have to be able to travel to that. Why are we not doing, if our goal is to teach kids to swim, why are we not doing it during school term, where we, to coin a phrase, you fish where the fish are?
I understand that. We're looking to build a recurring programme. The first objective there is to build on the Commonwealth Games and the Summer of Sport, and ensure that there is a response to what we hope and expect to be a considerable enthusiasm for people wanting to emulate the sporting stars that they're going to be able to see here in Glasgow again. This is recurring funding, so this is going to be funding going forward that can build a programme, and whether that is in term time or whether that's in the holidays, we'll continue to work with governing bodies, in this case Scottish Swimming, in order to build a programme that works for to make it as accessible as possible. Because I do recognise the accessibility challenges. I was speaking in answer to Emma Harper earlier around the impact that child poverty plays, and the differential impact that poverty has in terms of outcomes and health and well-being. And accessing services is another area in terms of the poverty premium that applies. So we'll continue to work with Scottish Swimming and others in order to ensure that the services that are being provided are ones that are as accessible as possible.
You touched on legacy there. And I think legacy is a hugely important tool to use in terms of engaging. But we had, in 2014, we had the Commonwealth Games were here in Glasgow, and it showed, I think, Scotland at its very, very best. Some phenomenal sport. However, the legacy from that Games has not been evident. A lot of closing down of facilities, being able to access sport, being able to access physical activity is becoming, I've said this many times, the bastion of the middle classes in private education. And that is very, very evident. You'll be aware I've been a coach forever, longer than I was an athlete, and it is a concern. So how are we practically, because we've got a fantastic summer of sport coming, where Scotland once again will be shown as a key deliverer of major events. How are we going to make sure, given the issues I've told you, that we maximise that legacy and deliver that legacy?
Yeah, so that is, Mr Whittle's absolutely right, that, and this came through as part of the discussion that I had with the Scottish Football Association last week. There's no point in us having one-off events that are then not sustained, that we get loads of people in and then they don't sustain participation. That's not a legacy. What we're looking for is to build a legacy, and that's what the governing bodies are looking for as they're developing their programmes. I can say that having spoken to one of them in the SFA in terms of the programmes that they're looking to build. And from the SFA's perspective, it starts with their community clubs. I declare an interest. I coach one of them, and ensuring that broad appeal and accessibility and support is, I know, in the Community Football Club network, an incredibly important aspect for them coming forward.
And I expect that to be replicated in other sports governing bodies and the plans that they bring forward. It was certainly part of the discussions that we had pre-budget around what they would be able to do around participation, how they could broaden participation and accessibility to people from lower income families. So I know that that is a key consideration that's been brought forward in terms of the governing bodies and the programmes that they're seeking to offer, and how they will seek to ensure that going down to the athletics club network, or indeed to the other sports networks at a community level, that's where we make the difference. That's where we're able to make these offerings more accessible.
I suppose I better declare an interest as an athletics coach as well, but what I would ask the Cabinet Secretary is go out and speak to other sports as well, because we are struggling, and it's a financial issue, and somehow or other we've got to utilise this summer of sport to rejuvenate a lot of sports, because they are on the decline. There's too many clubs shutting down.
Well, the intervention that we're making on this budget was in response to governing bodies setting out concerns like that. I can see some of those concerns. My children participate in athletics and swimming and football, in a range of different sports. So I can see the strength that there is in the club network. I can see the strength that there is in the community network, and the volunteers that allow these clubs to be sustained. And again, that's another element around how we can continue to support the volunteering in sport across Scotland, because that is the lifeblood. That is what empowers and allows clubs to be able to put on sessions and to be able to take on additional teams, to be able to have more children and young people involved. But we also need to look at how we ensure we're providing accessible services for adults as well, that may well be looking at the Football World Cup, the Commonwealth Games, and looking to get back into a sport they've previously participated in, or looking to pursue a more active lifestyle, looking to get involved in something like walking football or the Jog Scotland network, in order that we can get for them to be able to get access to a more active lifestyle. So this is a broad investment that we're making to provide an opportunity for increased participation across demographics and across age groups. And I'd be more than happy for either myself or Ms Todd to be able to meet with Mr Whittle to be able to discuss that in more detail with him.
Much as I feel I'm just getting started, Convener, and I realise we're running out of time, so I'll leave it there.
Thank you. And Elena Whittle.
Thanks, Convener. I have a few questions round about the Good Food Nation plan. So the committee took evidence and published our report in September on it. And one of the things that we came to a conclusion on was that for success in ensuring that the plan itself resulted in a better diet and improved health outcomes, there needed to be a clear line of sight to the goals of the plan across very different policy areas. And we know that there's going to be competing policy areas in here. And we've already spoken this morning a little bit about trying to break down the siloed approach. So my question really is round about how will governance and funding decisions be reached in a way that will prioritise public health and a healthy diet, given the competing pressures round about thinking about the economy. So if we think about those products that may have an impact on health, where they may have priority in another policy area, how do we ensure such products actually are going to be thought about in terms of the Good Food Nation plan and health outcomes?
I thank Ms Whittam for her question. This is an area that we have been exploring in depth around how we balance the public health interventions that we need to make with providing increased choice, because in some cases on food and nutrition, but also in alcohol, choice is being curtailed, and it's making it more difficult for people to be able to make decisions on how they sustain themselves. So that we're taking forward, as Ms Whittam will be aware, public health interventions around minimum unit pricing, but also around high-fat and salty, sugary foods, recognising that their impact on health and well-being in Scotland. There are considerations, of course there have to be considerations around the wider economy, but that flips both ways in that, and I say this as a former economy secretary, that you struggle to have a growing and successful economy if you don't also have a healthy workforce. And I think ensuring that we have that balanced approach means that we're able to take the necessary interventions that protect health, but also then sustain a healthy workforce that contributes to economic activity as well. And that is the overarching approach that government is taking to the Good Food Nation and also our public health measures in improving accessibility and choice for people in terms of their eating choices.
And so in terms of monitoring the implementation of the plan to ensure that public health outcomes and the prevention of ill health and indeed the promotion of healthy living, how is the Scottish Government going to actually monitor the effects on health inequalities and make sure that they are prioritised? So from your perspective as the Cabinet Secretary for Health, how are you going to do that?
So I have good engagement with Ms Goujon, who obviously leads on this space. I believe the legislation gives us an opportunity to be able to do that. And I'd be happy to provide more detail to the committee in writing as to the monitoring that we expect to put in place and the decisions, the decision-making infrastructure that we have around some of the public health interventions that we're seeking to make as well.
Thank you.
I thank the Cabinet Secretary and his officials for their attendance this morning and their evidence to committee, and I will now suspend the meeting to allow for a changeover of witnesses.
Thank you.
The third item on our agenda is consideration of one affirmative instrument, the Civic Government Scotland Act 1982, Licensing of Non-Surgical Procedures Order 2026. This is a draft statutory instrument which requires approval by resolution of the Parliament before it can become law. The purpose of the instrument is to establish a licensing scheme for the provision of certain non-surgical procedures which pierce the skin and do not require the input of a healthcare professional. The order will ensure that these procedures are only provided from appropriate settings. It will designate the activity for which a licence under the Civic Government Scotland Act 1982 is required, as from the 6th of September 2027. The Delegated Powers and Law Reform Committee considered this instrument at its meeting on the 20th of January and made no recommendations in relation to the instrument. We will have an evidence session with the Minister for Public Health and Women's Health and supporting officials on the instrument, and once we've had any questions answered, we will proceed to a formal debate on the motion. I welcome to the committee Jenny Minto, Minister for Public Health and Women's Health, Rachel Cooks, lawyer, Owen Griffiths, Legislation Team Leader, Scottish Government, and I invite the Minister to make a brief opening statement.
Thank you, Convener. I would like to thank the committee for giving me the opportunity to speak about the Civic Government Scotland Act 1982 Licensing of Non-Surgical Procedures Order today. This order is part of a suite of legislation to regulate non-surgical procedures, a sector which is currently unregulated. These procedures can cause serious and lasting damage if they are not performed correctly, and this is one of the two substantive steps we are taking to reduce the potential harm to customers in Scotland across a range of procedures. The order sits alongside the Non-Surgical Procedures and Functions of Medical Reviewers Scotland Bill, which is currently at Stage 1. The order establishes a local authority licensing scheme for lower risk non-surgical procedures which pierce or penetrate the skin. These are procedures which do not require the input of a healthcare professional, as any risks can be appropriately mitigated through the imposition of hygiene standards and by requiring the use of appropriate materials. Procedures covered by the order include laser and light treatments which do not damage the skin's surface, shallow microneedling, fruit and glycolic acid peels, and advanced electrolysis. By contrast, the bill regulates a range of more invasive procedures where we believe healthcare professional input is required to ensure safe treatment. Taken together, this allows us to provide a differentiated and proportionate approach to the range of procedures available. The order sets out a number of mandatory licensing conditions relating to the hygiene of premises, equipment and processes. It also requires that non-surgical procedures must not be carried out on individuals under the age of 18. These conditions are key to protecting the public, especially young people, and they will give customers confidence in the services they are receiving. As with the bill, the definition of a non-surgical procedure in the order does not include procedures undertaken by a person acting on behalf of the health service or by a healthcare provider for the prevention, diagnosis or treatment of illness or injury. Where the removal of skin lesions are carried out by a person acting for on behalf of the health service or by a healthcare provider as prevention of treatment of an illness, this would be exempt from the definition of a non-surgical procedure. Again, as with the bill, the order does not include any provision for training or qualifications. This is due to the effects of the UK Internal Market Act, which we have discussed previously. We continue to work with the UK Government on this issue, and we will legislate for training and qualifications when circumstances permit us to do so. I welcome any further questions the committee may have and encourage you to support the progress of this order.
Thank you very much, Minister. And indeed, the committee does have a series of questions for you, so we'll move straight to those. And David Torrance.
Thank you, Convener. Good morning, Minister and officials. What is the rationale for classing higher risk procedures as suitable for local authority licensing rather than restricting them to Healthcare Improvement Scotland regulated settings?
So we have taken a lot of advice on this, and we've done a lot of work to ensure that we feel that the right procedures are given the right and proportionate regulation. We would expect local authorities to work closely with Healthcare Improvement Scotland to ensure that if there are any questions on the procedures being carried out under the licensed local authority licensed premises in this order, that they get it right. That's why, as I said in my opening, it's a suite of regulations and legislation to ensure that non-surgical procedures are given the right regulations.
Minister, how will the Scottish Government address concerns that non-medical practitioners could end up carrying out procedures on potentially cancerous lesions under a scheme, and how will a list of skin lesions, blemishes be reviewed or addressed for a risk?
So I think that's a really important question, and I know that you got very thorough evidence from both healthcare and also those providing non-surgical procedures. This is something that we will clearly lay out in the guidelines, but I think it is fair to say, and it ties in with our promotion around being the early bird and detecting cancer early. If someone is going for regular treatments, then the beautician, the person providing these treatments can notice any changes and then would advise to go to a healthcare professional, as one would expect. And so we would have guidelines that support that, because I absolutely recognise the importance of that and recognise the questions that you gave me the last time I was in front of the committee when we were talking about the bill itself.
Thank you. No further questions.
Paul Sweeney.
Thank you, Convener. I just want to touch on the regulatory boundaries and if the Government can respond to concerns that the distinction between respective scopes of the bill and the order may not be clear, particularly in relation to the technical thresholds of procedures, and will the Government commit to fund appropriate training for local authority officers to be able to navigate these technical challenges with enforcement?
So I thank Paul Sweeney for his question, and I think we have been doing work in this area specifically to understand where there could be the need for support between local authorities and Healthcare Improvement Scotland. These organisations already work together, but I commit to the Scottish Government working with them both to ensure that that is a much more collaborative process. We have got prior evidence of where this works together. For example, the Scottish Licensing of Skin Piercing and Tattooing Working Group, which brought different organisations together to ensure that there was that understanding and consistency across the different organisations that would be controlling it. But we are clear that if the procedure is in the bill, then that is a Healthcare Improvement Scotland responsibility, and if it's in the order, then that is a local authority one.
Thank you. I just also want to ask about how the Scottish Government will ensure that local authorities are able to develop this clear workable guidance, because obviously there are concerns that the distinction between thresholds such as microneedling depth and chemical peel penetration can be quite challenging to distinguish. So, procedures covered by the bill, procedures covered by the order will be quite challenging to distinguish on the ground, and just how can we be confident there will be clear workable guidance on those technical thresholds?
So before I bring in Owen Griffiths, I think all the work that we have done to get to this stage has been very clear, and the consultation responses, again, were very clear as to whether a procedure should fit under the order or whether a procedure should be within the bill. And as a result of the responses that we got to get that consultation, there have been some changes. But we have laid out in the order, in Schedule 1, the descriptions of each of the procedures that the order will cover. But I'll bring in Owen.
Thank you, Minister. I thought it might be helpful to provide a few examples of how that might work in practice, and the reason why this makes more sense in guidance than on the face of legislation. So you mentioned chemical peels. There is a distinction between the types of product that you'd be likely to use in a procedure covered by the bill and the SSI. And while I don't think it would be appropriate for the bill to list, or the SSI to list, individual brands or products or kind of compositions of chemical peel, that is the kind of level of detail that's quite appropriate to put into guidance, and that provides an unambiguous reference point, both for practitioners to know what is likely to be acceptable for them, but also for, say, an EHO could go into a premise, and if they see certain products being used, that would be a very, very strong indication that those are products which are appropriate to build procedures, and that they would know fairly clearly that that was the case. But as I say, that makes sense to us to put that into the guidance space, but we can provide some unambiguous steers of that kind of nature.
That's helpful. Just also wanted to ask about a method of escalation for officers in local authorities. Could there be an expert panel or some sort of troubleshooting service established at a central level, just maybe even in the early introduction of the enforcement mechanisms, just so that if there are borderline procedures or uncertainty, that could be referred for some sort of expert adjudication?
So I referenced in an earlier answer the work that was done with skin piercing and tattooing, where there was a working group. I'm not ruling that in or out, but I think that is a suitable way forward to ensure that we do have the appropriate training and understanding within local authorities.
Thank you.
Thanks, Convener. Good morning to you, Minister and officials. We were talking about guidance rather than putting something on the face of the bill, because some of these procedures, or the procedures, will evolve, and changes to chemicals or changes to microneedling. I mean, I'd never heard of it before we started this bill. So I guess my question is, we need to allow some flexibility because procedures will evolve?
I agree, and I think Owen Griffiths set that out very clearly in his response to Mr Sweeney.
Okay.
Thanks, Convener, and good morning to the Minister. The order doesn't set any knowledge, training or skills requirements for licence applicants. This is different from the Piercing and Tattooing 2006 order, which requires councils to decide specifically in relation to tattooing and piercing if an applicant is fit and proper based on their knowledge, skill, training and experience, or those of the people doing the work. It's not clear whether local authorities will be expected to make decisions on a similar basis under the new rules, or if guidance will be issued. Could the Minister provide clarity on this point?
I thank Gillian Mackay for her question, and I absolutely recognise the importance of training and qualification standards, and that too was very clearly reflected in the views of stakeholders in our consultation. We, as the Scottish Government, set out a clear intent that we wanted that level of qualification. However, the Scottish Government also believes that Section 3 of the UK Internal Market Act will be engaged by any legislation that sets out training or qualifications, especially standards for practitioners, but also prevents practitioners who don't have that qualification from practising. So that's something that when I give evidence for the bill session, I indicated that we have been in in-depth conversations with the UK Government around this, and earlier this month I wrote to Karen Smith, the Minister in the UK Government that's responsible for this area of public health, which I have copied to the committee. So this is an ongoing work, hence why it's not specifically included in these orders, in this order.
Given that this is a an element of safety for those who are accessing these services. What confidence does the Minister have that this will be resolved with the UK Government to make sure that there are those safeguards in place for people in Scotland?
So, as Gillian Mackay will be aware, the UK Government is also consulting on similar regulations around non-surgical procedures. So hence why we're working closely with them to understand where they've got to. We will also be working with current training providers to look at what the courses could be. That work is ongoing.
Great. Thanks, Convener.
Elena Whittam.
Good morning, Minister. I want to spend a little bit of time looking at local authority capacity and resourcing. So local authorities told the committee that they were concerned round about their environmental health officer capacity, because we know that there's a lot of vacancies at the moment in the system. There's also concerns that the licensing fees alone perhaps will not cover the cost of the system, especially in the start-up phase when there's a lot of training and development of processes and initial inspections that will be resource intensive. So I'm wondering whether you can set out how the Scottish Government intends to support resources or additional support-wise to ensure that local authorities can fulfil their new licensing duties effectively.
Yeah, I thank Ms Whittam for the question, and recognise from other areas of my portfolio as well as this one the stretch that is required for environmental health officers within Scotland and the absolutely key roles that they do across the board. So I recognise that there will be some additional work for local authority environmental health officers and also the licensing departments in processing licences. I also understand, though, that the EHOs are currently doing an amount of work in this area without any direct resourcing. So, and through investigating through health and safety concerns. So under the order that they will have the ability to source cost recovery, and it will be the local authorities that will set the levels of fees for the licensing. We will provide guidance, and clearly I see this as an important public health piece of regulation and hopefully legislation as well. So I will commit to work with local authorities and also alongside Healthcare Improvement Scotland to ensure we have the right structures.
One of the other issues that was raised with us is the fact that although they've been operating, dealing with tattoo and piercing since 2006, that this actually stretches their kind of expert knowledge to an area that they're maybe not so familiar with outside of their usual expertise. So I'm wondering if you can set out how the government and perhaps that expert group that you were talking about could perhaps facilitate that type of learning to extend their knowledge to cover this.
So I think this is really a replication of what happened with the tattooing and the fact that there was that group working together to ensure that there was that knowledge. So that's something that we have taken away and will be looking at.
Okay, and perhaps that group and the government, is that where national tools, templates, implementation guidance would be developed and provided to reduce the administrative burden on local authorities that I think they're also concerned about, and ensure that decisions are consistent across the country?
I think that's a really good point. I think we do need consistency across the country with regards to that. And I think there is a role for the Scottish Government to play in that. There is also a role for COSLA to play in that as well, and also the providers of these non-cosmetic procedures. And I would hope that that will be pulled together to ensure that we do have consistent regulations across all of Scotland.
Thank you.
Thank you. Whittle.
Thank you. Good morning to the Minister and your officials. You talked about, in replying to Eleanor Whittam there, around public awareness within the councils. But how will you commit to that sort of national public awareness? Because it's, I think it's really incumbent upon the government here to make sure that, one, the public know where to access the information, and two, they're aware of the status of the practitioner and what that practitioner can deliver. So how will the government go about dealing with that?
I think as we've been going through this process, it has been really highlighted the importance of that awareness, because I think it's fair to say that people assumed that this was already regulated.
Yeah.
So the coverage that you have been doing in taking your evidence, and also what's been on the media, whether that's radio, television or print, is all very important and has helped move us along in this this journey. I think it's fair to say that a lot of advertising for this type of treatment, these types of treatment, happen on social media, and the Scottish Government will look to share messages at the appropriate time in these channels. I think it is important. I think the awareness is very important, and you took very strong evidence on that as part of your evidence gathering for the bill.
Would it be the plan maybe to have a register of practitioner status that the public can access?
So what we're looking at is licensing, and I will think I'll maybe turn to Owen for that, because if you don't mind, Owen.
Not at all, no. So we've not really made any provision or made any announcements about kind of like a sort of Scottish Government organised register or a national register. However, it's already a requirement for local authorities to make available the information about licences that have been applied for and granted. Now, how local authorities do that varies, but I know some, so Edinburgh has a list on their website of premises and the licences they've been granted. And there'd be definitely space to work in guidance for making that maybe a consistent approach across different local authorities, and making that in a form that people can easily access. So there's already some requirements in that space already, and that can be strengthened through guidance.
I think Owen's right. It has to be in a space that is easily accessible and is easily understood by those using the facilities.
So just finally on that theme there, if we're going to have national guidance, which we're looking to establish here, how will we support that consistent implementation across Scotland?
So if it's national guidance, then we would expect that to be followed consistently. But as I've said to previous questions from Elena Whittam, that will be a collaborative approach with the local authorities, with COSLA, ensuring that we get the right information out in the right places.
Will Health Improvement Scotland have an input into that?
I think Health Improvement Scotland will have to have an input into that. I was specifically looking at the order, but if we're looking at the bill, if that becomes legislation, then yes, I would expect Healthcare Improvement Scotland to be involved too.
Okay, thank you, Camilla.
Thanks. I've just got a couple of questions on enforcement and rogue operators. So how does the Scottish Government plan to tackle unlicensed and covert operators? And will new enforcement tools or national protocols be developed?
So we have experience of rogue operators in other areas of my portfolio. So, for example, Food Standards Scotland work very closely with Police Scotland if they discover a rogue operator in the food universe. So I would expect here again, Police Scotland and the local authorities will have the powers to search unlicensed premises where there is sufficient evidence to suggest that non-surgical procedures are being carried out there. So again, it's that collaborative way of working. As I indicated earlier, local authorities have been using health and safety legislation, but this order designates the provision of certain non-surgical procedures and will give local authorities proportionate powers to regulate the provision of these in a consistent manner.
Thank you. And can I ask how Scottish Government plan to address concerns that temporary licences can be granted with limited scrutiny and that they might operate for extended periods? And what safeguards will be put in place to ensure such temporary licences don't become a loophole for avoiding proper regulation?
I think that's a really important question, and something that we will be working with the local authorities and COSLA to ensure that if there is a temporary licence permitted, that is for a specific length of time, and there is the right procedures in the guidelines to ensure that the licence is firmed up. That is in the interests of the local authorities as well as the consumer, because getting the licence will mean that they will get the resource to ensure that they can continue to monitor and regulate.
Thank you, Minister. I think we've come to the end of our questions. So we'll move to agenda item 4, which is the formal debate on the instrument on which we've just taken evidence. Can I remind the committee that officials may not speak in the debate? Minister, can I ask you to move and speak to motion S6M 20213?
Thank you, Convener and committee members, for your consideration of this order. The order will establish a local authority licensing scheme for lower risk non-surgical procedures which pierce or penetrate the skin, and modifies the general provisions of the Civic Government Scotland Act 1982 in that respect. The order aligns with Part 1 of the Non-Surgical Procedures and Functions of Medical Reviewers Scotland Bill, which together will bring under regulation a wide range of procedures that we know are happening across Scotland. These procedures can cause serious and lasting damage, and this is the first substantive step to reduce the potential harm to customers in Scotland across a range of procedures. I invite the committee to approve the Scottish statutory instrument and move the motion.
Thank you, Minister. I've had no indication that any other committee member wishes to speak. Do you wish to say anything further, Minister?
No, I'm content. Thank you.
Thank you. The question is that motion S6M 20213 be agreed to. Are we all agreed? Yes. We are agreed. Thank you. And that concludes consideration of the instrument. The fifth item on our agenda is consideration of a negative instrument, the Public Bodies Joint Working Integration Joint Board Scotland Amendment 2025. The purpose of the instrument is to extend voting rights on integration joint boards to include service user, unpaid carer and third sector representatives. The Delegated Powers and Law Reform Committee considered the instrument at its meeting on the 13th of January 2026 and made no recommendations in relation to the instrument. No motion to annul has so far been received in relation to the instrument. To support its consideration of the instrument, the committee has written to selected stakeholders to request their written views. The committee has received a response from the Convention of Scottish Local Authorities expressing certain concerns about the instrument. In light of this, I would propose that we invite a representative from COSLA and other interested parties, including third sector organisations and union, to give evidence on the instrument at next week's meeting, along with the Minister for Social Care and Mental Wellbeing. Are committee members in agreement with this proposed approach? Thank you. At our next meeting, we will take evidence from the Patient Safety Commissioner for Scotland on our initial work priorities since taking up her post in September last year. And that concludes the public part of our meeting today. Sorry, I should have said you can go. I just